Thank you for joining us today on MTVA Unscripted. I'm John Rodas, president of the Moving to Value Alliance, and I'm joined today by my colleague and partner, Dr. Steve Schutzer, esteemed orthopedic surgeon and co-founder of Upswing Health, Lisa Trumbull, one of our board members, the CEO and president of Sohn Health, Southern New England Healthcare Organization, which is an integrated clinical delivery network in Connecticut and Massachusetts. Our guest today is Dr. Arshad Rahim, MD, MBA, who is the Chief Medical Officer and Senior VP of Population Health at the Mount Sinai Health System in New York City. Arshad, thank you so much for joining us today.
Yeah, my pleasure.
Arshad, we've all arrived at this value and healthcare space from different directions. Tell us a little bit of your journey and how you got to the value and population health space.
Sure. Yeah, probably like all of us on this call, have the disease of many different interests, and how do you bring them all together? And so I would say for myself, an interest in service and caring for folks, an interest in business building, and then an interest in frankly, just driving an efficient healthcare system. And so that's been kind of the golden thread through my journey that originally started right after college in community health. I didn't even know the word population health, and then kind of chose to go to medical school, decided to go get an MBA before I did residency, then residency and practice for a little while, and then continued practicing, but have tried to really just build innovative organizations, whether they were on the private side or now within a health system, the not-for-profit side, to really drive the value equation and achieve the outcomes in a cost-effective manner that we deserve as a country.
Arshad, we go back a long way. We met actually 10 years ago at an orthopedic meeting of all things. Orthopedic surgeons are not really known for interest in value-based healthcare, but we did meet at that shifting from volume to value course 10 years ago. But I'm really interested in a number of things, because even though you're an internist and an orthopedic surgeon, our goals are the same. We see a better way, we see better outcomes, lower cost, but we're also physicians. And I think from the physician perspective, we still sense that value-based healthcare means we're going to get the short end of the stick. How do you deal with the docs? First of all, how many physicians do you oversee? And then how do you herd the cats? Like Kool-Aid.
Right, great question.
Starting softball, okay?
Yeah. What are my roles? What are the hats I wear? Yeah, CMO of the CIN. So we're about 6,000 docs, about 1,500 community, and 4,500 employed. Very large specialist presence, probably almost 3/4 or more are specialists, obviously being, as this is a CIN anchored within an academic medical center. So yeah, it's been very interesting, that piece of it. Luckily, I guess for me, father's a cardiologist, grew up in a physician community. There wasn't a whole lot else in Newport Richey, Florida, not to offend anyone from Newport Richey who's listening, but that was it. So I grew up a lot around healthcare and doctors. And so naturally, even going back to about 2007, just the ability to kind of, I'll be frankly, engage physicians in kind of new thoughts. And it was less value-based care then. It was even just service lines and was doing that work. And then now with value-based care, I agree with you. It's a bigger sell for primary care, automatically, just naturally. The reimbursement model, the time demands, they're largely unsustainable for primary care. And I actually did a primary care residency. And part of the reason that drove me into this career path was I was like, well, this is not so great. I don't think we're going to get a lot of other people choosing this if we don't change it. I even noticed that during residency, and I had don't mind share, I was at a great place that you all are not too far from. It was the Yale primary care track, and had some really open-minded big thinkers who kind of helped me think through it too, as to how we made an impact over a period of time. But just to kind of focus back, the specialist piece, I think medical subspecialties, often you can get buy-in. There's kind of a natural synergy. And interesting, Steve, just by meeting like people, I'm very fortunate to meet people like you and other very progressive orthopedic leaders. I would say even where I work now, our chair of our department's extremely progressive too, running a major campaign on osteoporosis, things like that weren't always driven out of the Department of Orthopedics, and the medical management of that even. upstream. I remember even one chair of a department came up to me after I was kind of talking about the CIN very early on when we formed it and said, is this just another way for the hospitals to take money out of the doctors' pockets?
There you go.
And literally that was after my presentation. And I kind of approach it that's how most of them are thinking. And then I got to start from there and kind of work through it. The financial models still need to be figured out at a broad scale. And that, let's just be frank, if it didn't have financial benefits for a lot of primary care doctors, it probably would at least take off to the level it had. And I think we really do need to think about that further on the specialist side. They're over half of the medical spend. And also through some of the national boards that I sit on in value-based care, I know it's very top of mind for CMS as well. So,
yeah, I think that's a great summary to hear how you've navigated through this and got to the point that we're both aligned in a similar way that population health and value-based care offer some opportunity to improve health outcomes in the system for patients, right? Versus the traditional fee-for-service model. So what I'm wondering is, for the employers that are out there and for the work that you do with your team, can you explain to them how this works practically and how it drives value for employers? And then maybe explain a little bit about what it means to do population health and value-based work.
Sure. So, I really look at it as kind of four major pillars that you're focused on. One is kind of, primary care and frontline provider engagement, because we are not necessarily strong in that. And that can be, your cardiologist, it can be your GI doc, but yeah, definitely primary care is very foundational. And how do we really get everyone established with a primary care doc that they really feel connected to and really feel as the quarterback of their care, regardless of what age they are? And especially in the employer market, New York City still have a lot of younger folks that want to come work at some of the large companies here. And yeah, they do have health needs and health interests, and we need to meet everyone where they're at, regardless of their age, and have that primary care engagement. So that's one piece. The other, and maybe I'll jump around a little bit here, but for employers, managing your healthcare premiums is what population health is very well suited when done at scale to really be a value add to all size employers, especially large employers. It is actually kind of a market space that we are very interested in servicing. Believe we're well positioned through our capabilities, currently managing about 500,000 lives in a variety of value-based contracts and 200,000 with downside risk. And so that's the attraction. But kind of going back, I mentioned primary care engagement. I think the other, from an employer perspective, really in general, trying to avoid the ER and the hospital as much as possible. I've been a hospitalist too, good part of my career, but I will say I agree with the hospital is no place for sick people, kind of mantra that, there's so much we could do. And if we do it in a coordinated, proactive, systematic way, then we can really avoid acute care. And I don't care what ER you're in or what hospital, you usually don't want to be there. You'd rather be, outside of there. So that's, I think, another very attractive piece. Obviously, people's, productivity or recidivism rates at work, in that this can be very helpful there. And there are, in terms of access, and we do need to kind of risk stratify the population and have various appropriate kind of disease prevention and disease management programs, all the way up to kind of what people are eating. And that I would say that is an area that we could do more of. But those are a few of the major pillars that population health offers to employers.
It's funny, before when you were talking about primary care physicians saying population health is just a way to take money out of our pockets, I was kind of smiling to myself as a former hospital president. I used to say the same thing. Population health is a way to take money out of the hospital's pockets, because, to your point, if it's successful, you'll keep people out of the emergency department and out of my cardiac care unit and all the places that hospitals make pretty high profit margin. So with that, let me segue into how do you manage all that in a health system that is still fairly dependent on hospital revenues for their business model. Population health, as we just articulated, kind of goes right in the face of their revenue stream. You guys were great. I mean, Ken Davis, I think, was a visionary kind of leader there. You have a new leader now, I know, in Brendan Carr. How does the health system approach this and say, listen, we're a low margin business now, healthcare, let's face it. And the insurance companies are clearly not suffering financially. How do you guys balance that from a system point of view?
I would say it still can be a challenge. And whenever I say it's not about decreasing volume, it's about ensuring the right volume is actually the acute care setting. And everyone tends to agree with that, I can stay busy enough with just the right volume. And then if you really get down to kind of the CFO finance level, we want to manage all populations, but let's just be honest, we are in a crisis in our government payer reimbursement right now. And that's still the fastest growing group. It's the fastest growing group in New York City. So Medicaid and Medicare, those are non-profitable acute encounters on the ED side and the inpatient side. And it's better for the patient to not have ended up there. So it can be a real win-win. And then obviously you're not going to make the hugest margins off of sepsis and those type of things. But obviously, surgical cases, advanced surgical cases that require inpatient stay, those are much more higher margin. So I don't think it's that they're divergent goals. I will say, John, and very well as a hospital president, how a lot of hospital executives think, and not all of them agree or get it or whatever you want to say. So it's a process.
Yeah, Arshad, I want to touch base on something that you said, and then John's counterpoint from the hospital perspective about whose money we're going to be taking with value-based healthcare. I think it points to one of the fundamental problems in healthcare, and that you and I were raised, and probably everybody, that it's a zero-sum game. I think that's a fundamental problem. I don't look at it that way. I look at an amazing opportunity for all of us to do well, except for the people who don't deliver value. You know who they are. So, we created that monster through the AMA ruck, where whoever had the biggest deal there got a little bit more, and usually primary care docs got a little bit less. And then that cultural rift between specialists and the primary care docs have grown over 3 decades. And exactly what I mean.
Exactly.
And I don't look at it that way. And I think that's really important as we form a CIN where we're all in it together. It comes back to that book, John and Lisa, finding allies and building alliances. We all have a common enemy, and who they are. But we've got to get into that Professor Porter mindset of a positive sum. And one of the reasons why we had success here at the Connecticut Joint Replacement is because we're able to prove that through our attempt at value-based healthcare with bundles and the centers of excellence. The docs did better. They said, oh, this can work, right? It is true that it didn't come at the expense of the enemy. The hospital took a little bit less. But I think we have to fundamentally get out of that zero sum. There's plenty to go around.
Yeah, I agree, Steve. I think that one of the challenges with value-based care vis-a-vis the primary care specialty relationship is this fact that there's a zero sum, there's nothing in it for me. So why am I going to do anything to make it better? You've got primary care on one side with depleting incomes that aren't anywhere near some of what the specialty incomes are today, right? And that's not survivable as is the practice environment. Yet they need to be the quarterback, and they're burdened with all this additional work in order to manage patients in a population to, a conclusion. So they feel very strongly about the reward mechanism associated with that. But I do think that there is a place for specialists to play. And I'm interested in Arshad's response on this and what you might be doing with specialists, because when we look, as an example, look at our populations that we manage, it's the same stuff we all hear, right? Diabetes, congestive heart failure, chronic pulmonary disease, kidney disease. And a lot of those conditions require specialist engagement and management of the patient population. And, CMS has had their fits and starts on, chronic care bundles and, different methodologies to get specialists engaged. But I'm interested in your perspective on this in terms of specialty engagement and what you might be doing in this area.
Yeah. Well, Lisa, totally agree with how you phrased it. In fact, I'll just build on that. Yeah, our initial foray, and my focus, I think, as a lot of us, is like, let's just get started in doing things, and the proof will be there. People will join in, and we don't need everybody. I just need a couple champions here and there, and then I could bring the other 90% along. So what we did is we looked at roughly about 300,000 lives and said, what 6 disease states we believe are malleable and drive a good amount of cost? And it was, exactly some of the ones you were mentioning. So diabetes, hypertension, CKD, CHF, COPD, and peripheral arterial disease. The last one, it's been nice. We've had talks on kind of the forgotten chronic disease of PAD, and the metrics there are even worse than the other areas that are not great in terms of goal-directed medical therapy and care standardization. So that was kind of, we wanted to do it, and it naturally, obviously, aligned us with our specialist colleagues in each of those areas, including vascular surgery, cardiology, pulmonary, all those areas. And so we developed, essentially, I will say this, from our colleagues at Intermountain, kind of borrowed the idea of care process models in those areas, developed them for those 6 disease states, kind of call it the Mount Sinai way. Have a care pathway that not only talks about the clinical, but also all the coordination and how you should look at it. And then we've built registries to essentially say all the active patients within Mount Sinai Health System and that have those conditions. For example, I know the 43,000 patients that have heart failure within Mount Sinai. And then I could say about 14,000 of them are in value-based contracts. And then I could kind of work from there. And one thing is and we all know this, the most powerful influence tool often with physicians is data and understandable data, and so then it gave us the entree to have the conversation, just having that data to be able to go in and provide something to, let's say, the chair of pulmonaries. We can identify, all your COPD patients that are connected to the system. And then we built a dashboard in terms of with 5 metrics of how they're performing. And then we can geographically kind of hotspot maybe where the biggest opportunities are and work that. And then you, chair of pulmonary, you're the quarterback of this. And frankly, this could be your thing, in a lot of ways, and we will help just deliver because we're aligned. So that's been kind of, one approach, disease management. And we could stretch that into many other areas. Like I mentioned, osteoporosis now is one. We have a large sickle cell population, so our hematology department, IBD is another one. We were fortunate enough to have Dr. Crohn's as a doctor at Mount Sinai many years ago. So we're probably a little arrogant, but we do say we are IBD. We take a lot of pride in that population, but there's a population health approach to all of these. And then we've been working at there's doing the right thing for the community, being able to market our outcomes so that maybe also you can shift your payer mix some, or at least add on to it with, employer groups with these conditions. And then there's also the working through the financial models of whether we go to certain payers to bundle these services or be very ready for what comes out of CMS. So we've had some good traction, and I just do want to mention that actually, and I think this is only going to grow. I do, it's fun, have to have you all on a lunch and learn series that I do, but I brought the new chief population health officer at Vanderbilt, is actually a urologist and worked at CMMI. And so I think there very well is a path, and I think we're figuring it out. I don't think it's all figured out. I mean, frankly, people like Steve have really kind of led the way to prove that it can be done. But I think there's a path, and I think it will grow exponentially in the next few years.
Yeah. Arshad, that was great. And you piqued my interest. I was going to ask you about data. And you mentioned data, and I could read Steve's mind too, thinking he's thinking the same. So tell me, let's go. I'm going to take it now from the C-suite where I was before, right down into the clinic. So I'm there in front of the patient, and you've alluded to a lot of things in that last answer. We're talking about the continuum of health and disease, right? Because people don't get those things in isolation. It's really a continuum, right? And even you've probably read the recent thing by the American Heart Association under, what do they call it now? Kidney metabolic disease. And stage 1 disease is obesity. It's maldistribution of fat is actually, they call it stage 1 disease. And then, of course, you go on and get hyperlipidemia and hypertension and diabetes, and eventually you have a stroke and heart failure and all the other things that happen. It's not like those things are in isolation. So let's take it down into the clinic. And how do we use data? The clinician, by the way, could be nurse practitioner, primary care physician, whoever it is, has the patient in front of them who is on that path towards getting those conditions. Because that's the real opportunity, right? The holy grail here is let's prevent those chronic conditions from happening in the first place. But at least once they start to get them, is either nudge the people back to health if you can, or at least manage them well. We don't have a great track record in America for managing at the very early stages, right? When you still, all you have is obesity and diabetes, or obesity and hypertension. You know, the train has now left the station, right? So tell me how we drive the behavior change for both the doctor and the patient, because both have to change their behavior, right?
Yeah, no, it's such a great question. It's funny. I was asked to sit on a panel on sugar addiction a few weeks ago, and I'm like, what the heck am I'm going to offer nothing. I should be in the audience. And they're like, no, we'd like to hear your perspective. And so I joined, and it actually, the keynote was by a neuroscientist who's part of Mount Sinai that I didn't know, who wrote a book on sugar addiction and how it's, just like every other addiction. And it was really fascinating. But anyways, I bring that up to say that if you take the three areas of public health, wellness, and population health, too often they're quite silent. And I will say this as a population health executive is that, I've been in rooms over the years where we even had a conversation of like, okay, does wellness pay or not? And then the conclusion, unfortunately, which is really fortunate, is no. So let's not focus there. But I think that's got to change, because I totally agree with you. We're not doing enough at the early disease states. I do think one of the challenges is how do we, outside of kind of self-funded or pure how do we make the reimbursement model work for this? On a systematic basis. I really hope, as someone that still hopes that health systems or even large physician groups, it's not just the private industry sector as part of solving it, that we can figure this out so we can be part of it. And and we're seeing a very interesting time right now with GLP-1s, where it's just about it. That's unsustainable to not do the upstream stuff, to not focus on the wellness and do what we're very akin to doing, either, operate, scan, or give you a pill, and that's, so I don't have any of the answers, but it made me recognize, and that's why I went and sat on this panel, is we don't talk about this at all in population health enough. It just doesn't come up. It's much more later stage, but it needs to happen. I think CKD is a good one that there's a lot of interest. We've even developed early stage screening and built a company around it. And I think there's a wide variety of areas.
I love the combination of the thought process of public health and population health. And I think there's a lot to be done there. And I think, while I'm not usually looking for the government to solve some of our problems, I do think there's a tremendous role the government can play, but particularly in educating the public on how they're literally killing themselves.
Yeah.
And I'm not to segue too much, but there's a special that Oprah just did on obesity and GLP-1s, and they're talking about the disease of obesity. And I was having a debate with somebody yesterday about it. I said, well, okay, I understand disease and I understand obesity, but 50 years ago, there wasn't an epidemic of obesity in our country. Now there is. So this disease we're talking about seems to me it's based on behavior. And I could tell you 50 years ago, when I used to drive from Brooklyn, New York to Western New Jersey, for weekends, there was not one fast food place along the way. Not one. You'd have to stop at a diner and actually get a meal if you wanted to eat something, right? Now there's every 200 yards of that 50-mile stretch, there's a fast food restaurant with calorie dense, high sugar, high salt, saturated fat, high sugar, inexpensive food. So, that's where I think there is that interplay.
No, that's a good point. Food has changed a lot in 50 years. It's not just that, it's all the preservatives and other stuff that we add to it that create a cycle of, to your point, addiction to sugar. And the idea of food as medicine is a new concept that, it's so foreign to people to think about that. You just can't exercise off a bad diet, right? People need help to think through this. And the preferable foods for your health are not the cheapest foods either. So there's an income disparity in thinking about how to resolve obesity. And just look at the studies of school meals for kids, right? This was just recently. They found that when kids have meals provided in the school system, some of which aren't the best meals, they can dampen the effect of obesity, because then they're not going home and eating other types of foods that may be bad for them. But I like what you're saying around the system itself, right? If you think about obesity as a precursor to diabetes and hypertension and everything else, when you think about the way our system was built, it was built to be a break-fix shop, right? Oh, you've got something wrong with your knee, we call Dr. Schutzer, right? And you go and you get your knee fixed. It was in the reimbursement system was built to support that break-fix shop. It was not built to prevent everything from happening to begin with. And I think it's doing the right thing and focusing on the prevention, I think will downstream impact everybody positively, primary care, physicians, and patients. But figuring out how to do that within the system that exists today is really challenging. And I'm wondering if you're seeing any, anything on the horizon that gives you a gleam of hope that might be pivoting and moving in this direction, or there might be some willingness to consider modifications to the underpinning financials.
Yeah, no, great question. Yeah, and I was thinking about the one thing that jumps out to me as an area of opportunity is even, part of Medicare Advantage is survey metrics, we know. And the health outcomes survey, which still is about a third of the payment in Medicare Advantage, potentially even very tangible things of starting there with questions that drive, did your healthcare practitioner discuss your diet with you in the last 6 months? I think those are some tangible ways to at least get it on the radar and begin to, quote unquote, tie some money to it. I had a lot of fun in business school, but learned a few things. And the one thing I learned was, whatever the system is financially incentivized to do, it usually does. So I think that's where that's what we have to create. I've always thought of the Haas survey always comes to mind as something that exists, and you could start to add questions to that extent. There is, definitely are, I don't know the data, but, we obviously, like a lot of health systems or other organizations, we have a self-funded insurance plan. And our employees want to lose weight. Our employees want those programs. And so a little further upstream, there has been more momentum there than, frankly, in my quote unquote non-employee value-based care population. So that's where maybe if I took the 100,000 Medicare Advantage lives, and let's say now, and obviously that's an older group, you'd love to do this upstream, or maybe make it part of commercial VBC and start to add some incentives there. But the metrics, I think, could help us. And that would be a systematic way to do it. Maybe if NCQA took on some of these as like trying to design some metrics and then, be the measured stored, and then a few people could pick them up, and then we could start the momentum there. Just a few thoughts.
Yeah. Arshad, I want to come back to something that's always interesting. And I love having you on this podcast because one of our primary responsibilities as a healthcare leader is to change behavior. And there are two ways to do that. You can try doing it by fiat, right? The hard approach. Good luck with that. It's just not going to work. And the other one is with the gentle art of persuasion. And I find that the best tool, at least it worked here, was credible data, coming back to data. Yeah. And it's got to be credible, and it's got to be both sides of the value equation in terms of outcomes and cost. And it took us here in Connecticut 2 years to get the data to be credible. So for that first 2 years, I was doctor number 11. We weren't ready to de-identify it, but we went through a 5-step adjudication process. So by the time the data comes out the other end, even the most skeptical of my colleagues would say, hey, I got there's no way around this. I didn't think I had any infections last quarter, but guess what? I did. Patient was treated in Florida or in New York City. So I'm just curious, how are you using data to accomplish that goal, to change that mindset?
Yeah. No, that is our most important kind of tool in it. So I will say one thing, whenever we're asked, and I've used been asked by, foreign country that wants to build a pop health infrastructure, essentially 21 ACOs for the entire country. And I said, the first thing is data. You got to build a data infrastructure to do this. And yeah, the combination of all data sources into a data mart. And I agree with you. We started in our primary care. We have a primary care bonus. We started about 7 years ago that's just on value-based care. It included all of our employed doctors, and definitely appreciate our forward-thinking system in terms of being able to fund that beyond whatever the negotiated salaries were. But honestly, it took us about 4 years, I think, to really get the data where they were very comfortable with it. And that's kind of the time frame. And so then you look at other sources, and I'm dealing with this right now. I'm a CIN with a large number of specialists, and there may be a few specialties we can pick off on the quality side, and I'll continue to work on it. One area that you can kind of cut across is the cost side, risk adjusted cost. So that's another area of visibility that could maybe get to faster and scale it across. Like, I have the chair of cardiac and the chair of ortho all interested in the data. For me to divine their measures, and it's just going to take long. So we're going to start off on the cost side with kind of risk adjusted bundles within certain shadow bundles within certain disease states. But there's no other way than taking the time with it and knowing that you're probably going to end up with version 10 by the end. You will start off with version 1, but it's an iterative process. And the key stakeholders will be engaged throughout it. And they can help define it. And that's the huge part. And I'm a 200% believer that no one truly manages docs. You got to steer them in one way or the other, the best you can do. It's really a game of influence and engagement and respect. I think the word you used is, it'll never get you there. It'll never get you there.
It doesn't work.
Arshad, part of the challenge with us in quote unquote managing physicians, as you say, you can't manage, is we train these folks and we select folks who may not actually be ideally suited for the world we've just alluded to. And so with that, let me ask you perhaps a final question, which is, where does medical education, both graduate medical education, undergraduate medical education, residency programs, fellowships, where do they fit into the world? Because I'm on the faculty at Quinnipiac, and I give a talk on screening and prevention. And, I feel like it's not really new what I'm telling them, but 9 out of 10 of the leading cause of death in this country are modifiable, preventable, delayable. But that's not the way I learned in medical school, right? I learned, you say gout, I say colchicine, right? You say diabetes, I can name all the types of insulin and how fast they work. But we don't learn about the continuum of disease, and we don't really spend a lot of time about prevention of disease. We don't ask about diet because we don't want to know the answer, because we don't know what to tell the patient, because we had one hour lecture once on nutrition.
Exactly.
So where does the medical school fit into this, and residency at Mount Sinai fit into this equation?
Yeah. No, it's a great point, and I still think it's an area to be solved, like a lot of others. It is a journey. Some tangible things we've done, and we could definitely do more and would love to do more, is say more. There is a leadership track within our IM residency, and we always have value-based care as a part of it. And then there's also the interesting part of a lot of our residencies are more inpatient oriented, but that's not bad. Being cost effective in terms of delivering inpatient care. We need that kind of same focus in the ambulatory setting. Our pop health team does regularly do the practices that we work with, about 45 different primary care practices. Some have trainees. And so they become part of the training and even the measurement. And especially if their results go up to their supervising faculty member, it helps a little bit. But these are all very kind of small efforts so far. We don't have anything really built into the curriculum. I will say that one interesting thing where we're starting, this is a little later, but young physician leaders who want to go into administration and that we identify as high value, put them through a young physician leadership program, of which we're actually looking at 12 weeks now in ambulatory and pop health. And they do 6 weeks in ambulatory, 6 weeks in population health. And that's another way to kind of tie that together for them so they can hopefully drive. But it is, there definitely is, I get a good amount of interest, but I'm doing everything one-off, from whether it's a medical student or whether it's a resident or even a fellow. I'm doing everything one-off, and yeah, it needs to be a little more systematic. And there is always, obviously, it'll never go away. I still always remind them your first job is to be good in your clinical area, and happy to support you otherwise. But I do remember it was big for me. I actually got to do a rotation during my residency with the Yale Health Plan. And our program was forward thinking enough that I could do that for 6 weeks. And that's impacted me my entire career.
Gosh, I remember distinctly 7 years ago, your former CEO got national attention when he said, "If our beds are filled, it means we've failed." Do you remember that, Arshad?
Oh yeah. Yeah.
Yeah.
It's got attention.
And yet our beds are filled.
Yeah, that's very forward thinking, very progressive. Lisa
Yeah.
hit him on the head. Great. Arshad, thank you so much for joining us today. I really appreciate it. It's always good to talk to you.
It was a lot of fun. It was good to listen to you and hear your perspective. So thank you.
Really
No,
good.
thank you all. This was really, I could chat with you all day. So this was
Good.
great. Love learning from you.
Thank you so much, Steve Schutzer, Lisa Trumbull. With that, we will sign off, and thank you all for joining the Moving to Value Alliance Unscripted podcast.